through this class, we begin to build first some awareness of disaster preparedness so that we are all, there's 16 people in this class and me and some instructors are on. We are then armed with the tools to prepare ourselves to mitigate risks in our home, to be prepared in ways that mean that we're going to be we're going to reduce the chances that we're all going to be victims. We're going to be less of a drain on already very strained emergency personnel. So that's the first thing we're putting in our CERT backpack. CERT organization, you know, you bring a bunch of strangers together in a neighborhood to try and work together to help if there's a major disaster. And how do you work together? How do you organize yourself? Who's going to take the lead? All of that is a beautifully simple system. And we've learned that. Then we start to bring in some light professional skills. We started with medical operations. Tonight we have a trainer, Anne-Marie Jensen, who is going to take you through medical operations 2. We're going to talk about disaster psychology because obviously, you know, we are not professionals, most of us, some of us in the room are, but you know, we're not professionals, and we're going to probably experience personal trauma, see others experiencing trauma, and having tools to deal with that is something we're going to talk tonight. So that's another thing in our CERT backpack is we're building skills. Then we're going to get into, we have 2 more nights. We're going to get into light search and rescue and emergency communications. So, you know, those are the last of the semi-professional skills, and terrorism is the final, which is not really about what we're going to do as CERTs, but as human beings in this world, as citizens, watch outs and what we can do. So the whole goal being that instead of being individuals, we're going to have skills to work as a team with one another. We're not going to be unsupported. So that if we're activated, then we can plan in an organized way. We know how to organize ourselves in roles. We have safety as our first priority. So hopefully you're beginning to pull that picture together about what we're trying to achieve. Now, I asked you to bring this document, which is the CERT field operations. This is a really valuable tool, and you want to be looking at this, particularly as we start the build for March the 18th. And remember, March the 18th is not a test. You're going to be working together in a team. So this field operations guide, it includes some of the salient tips related to things you're going to do and things you need to remember as a CERT if you're activated. So if you open it up on the side that has the logo, you will find the triage procedures that Karen Lum went over last week. You'll see the start triage process, start where you stand, that she talked about. Anne-Marie tonight, our trainer tonight, is going to talk about the head-to-toe assessment. You all watched a video on that. There are a couple of panels about checking for respiration, checking for perfusion, the circulatory shock cautions, that 32 can do that you learned about and that you went through that exercise. And there's a very handy CERT equipment list if you're interested in that. There's information on how to treat water because sanitation is going to be critical in a disaster. And then as you go to the reverse side, we're going to start building on some of those skills. So there's emergency radio skills. When we do the light search and rescue unit, you're going to, we're going to talk about how to lift somebody using the blanket lift, a team doing that. Search markings so that when we enter a building, it's known that we're in there, or when we come out, it's known that we're out and what we found. Leveraging and cribbing, you're going to learn on March the 18th. So this is a really valuable tool. I encourage you to utilize it as we go forward. Anne-Marie Jensen is with us. Anne-Marie is a Walnut Creek CERT. In her career, She worked for the Oakland Fire Department for a number of years. Then when she retired from the Oakland Fire Department, she was a firefighter. When she retired, she opened her own business providing emergency preparedness skills to Silicon Valley businesses. So we're really lucky to have her, very grateful to have her. She's still an active EMT. So Anne-Marie, I'm going to let you show your slide.
Good evening, everybody. Well, difficulties that we're having this evening is a perfect entree into what it is that we're going to be covering today, because one of the things that I like to say when we're talking about all things CERT is we have to be prepared for changing conditions, because when you are responding to during a situation, it usually and very often is a dynamic situation, which means that you start out thinking one thing, and as time goes on, can evolve or devolve into something completely different. So we're just gonna charge on ahead here. So as we show with any one of these modules, we kind of reiterate these kind of like the same mantra over and over again, because these are really, really important key points. Your personal safety, you as a responder, is always the number one priority, right? And if we haven't said it enough yet, you're going to hear it a lot more going forward. Okay, show up when you're activated or when you are self-activated. Wear the appropriate stuff. Make sure footwear is really important, because if there's a disaster such as an earthquake or something like that, the ground can be very very uneven. So appropriate clothing, that means layers, that sort of thing. Make sure that you have water, because you have absolutely no idea how long you're going to be at a particular area before you have a chance to actually take a break. Make sure PPE in your backpack. Make sure you've got your gloves. And when we're talking about gloves, we're talking about the leather work gloves. We're also talking about the nitrile medical gloves, helmet, goggles. I mean, you guys know the drill, right? You've got to have at least one communication device. You work as a team. So if you're working as a team, you're not expected to respond alone. You will always be working together with at least one other person. Sometimes, you know, if only one of you has, let's say, a radio or a cell phone, that's good enough. When responding, always maintain that situational awareness. Like I had said in the beginning, disasters are very often dynamic. Most of the time they are dynamic and evolving. So always maintain that situational awareness, and to assess whether you are in a safe place or are in a place that has the potential to become unsafe. Okay, so your goal, your objective when stepping up is to do the greatest good for the greatest number of people. And that's very different from your general first aid sort of thinking. We have to respond in such a way that we take in the greater good. Okay. So this particular unit, we're going to go through, again, reiterating your personal protection. It doesn't make sense for you to actually go into a situation unless you are appropriately prepared to keep yourself safe, as well as the people that you're going to be helping out. We're going to talk a little bit about sanitation procedures in a disaster, because this is a very, very important concern for any kind of situation that is going to go on for an extended period of time. As CERTs, it may be necessary to establish treatment areas where we're actually going to provide first aid help to people. We're going to talk about ways to do that. Head to toe, like Margaret said, this is an important ability for you to assess quickly and in a very general way what kinds of medical issues somebody may end up having as a result of whatever disaster we're dealing with. And to be able to recognize what those medical issues are. And also, we're going to be going through some basic disaster first aid. We don't have the luxury of having professional medical responders showing up right away. So it's going to be kind of on you guys to be able to provide kind of the essential first line first aid stuff. And we're going to talk about that. Okay, so let's jump into public health during a disaster. Everybody kind of is familiar with the Black Plague and the issues that many years ago. The plagues that humans have dealt with over the years were basically, and generally speaking, became rampant as due to a lack of sanitation issues. So I kind of put that slide up. It's just kind of give you some kind of an idea that, if nothing else, for us to consider our priorities as to maintain public health during a disaster to the best of our abilities, which is pretty simplistic stuff, but you are actually going to be working and helping people out. So in a disaster, we will not most likely have professional responders showing up anytime in the short term. So it's going to be kind of on us to kind of maintain a hygienic environment, not only for ourselves, but also for the people we're going to be helping. So how do we maintain proper hygiene? How do we maintain proper sanitation? Sanitation becomes an issue over time. We're not going to have the nice, clean, urgent care facilities, or we're not going to be able to necessarily get to the emergency room right away. So it's important that we maintain our environment in a sanitary fashion. I'm going to talk a little bit about the steps for purifying water not only for drinking, but also for use in administering first aid. And the whole point of this whole thing, of course, is to prevent the spread of disease. These are not necessarily onesie-twosie situations where you only have a couple of people that you're dealing with, maybe a household, something like that, but an entire community or neighborhood of people. So we have to kind of think in those terms as well. Everything is scalable. It could be a very, very small issue or a very small area of concern, or it could be something much bigger than that. So we're just giving you the tools and giving you the awareness to take that into consideration, that these things are scalable and could get bigger. All right, so proper hygiene. Okay, so as far as you in the field rendering care to people, okay, keeping your hands clean, okay, is very of course is critical. So frequently sanitize your hands, meaning washing your hands, whether or not you're actually on the medical team, whether or not you're on the medical team, whether you are part of another part of the incident command structure, keep your hands clean. And, we reiterate this same thing over and over again. Frequently sanitize your hands by washing them soap and water. Okay, soap and water is always better than alcohol-based sanitizer. But if that is all you have, if you're limited with your water, alcohol-based sanitizer is your next go-to. All right. As far as using medical gloves, changing your medical gloves after touching each patient. We'd like to think that that's kind of a no-brainer, but sometimes we have to kind of like speak of it specifically so people will know that. If you have run out of gloves and you end up having to keep your gloves on and going from one patient to another patient, sanitize your gloves as you are wearing them. Okay, you can do that with a solution of 1 part bleach to 10 parts water. You do the exact same thing using for 20 seconds using soap and water. But the point is, in the pinch, if you are run out of gloves and you have a current set of gloves already on that you can sanitize those before touching on your next patient. One of the things that I have done in real multi-casualty incidents where there are a number of different patients, before I've actually gone on scene, I have put several pairs of gloves over my hands. So basically, so I don't have to basically stop again and again and change gloves. And if I can basically peel off a pair of gloves, dispose of them, and I've got a fresh pair of gloves underneath. Okay, also to maintain, maintain proper hygiene, wear your N95 mask and goggles. And I know Karen Lum talked at length last week about the appropriate N95 or 95 a mask that you will want to use. Keep appropriate distance. When we talk about this, we don't mean like you stand across the the treatment area and administer help to your patient. What it basically means is use a little common sense as far as like where you're going to put your face. Okay, if you're going to be talking to a patient who is injured, for example, then you have body fluids around, whatever that works out to be, just be cognizant of where your face is. And so you don't accidentally get a splash of, let's say, blood or some other, body fluids, that sort of thing. Just, be aware, okay? If you're working with a patient to bandage, dress a wound, that sort of thing, try to the best of your abilities to keep those dressings sterile. Most of these dressings are already individually wrapped in sterile paper. Things can get really messy out in the field. Just kind of keep that awareness and be cognizant of trying to keep your dressing materials as sterile as possible. Okay. All right, so with all this stuff, you're going to generate some medical waste. Okay, medical waste is basically, gloves that have been contaminated with body fluids. It's wrappings, wrappers, gauze that's been used, that sort of thing. Anything that's been contaminated with body fluids of any kind, vomit, whatever, is considered medical waste. So we have to dispose of this in a very specific way. Now, what is available in the CERT cache and hopefully in your response bags as well are these red biohazards bags. And you need to check to make sure that you have a reasonable supply in your local cache to make sure, because that is how contaminated medical waste has to get disposed of. So gloves, everything. Make sure that these bags are actually tied off and sealed appropriately. Okay, if you run out of red biohazard bags, use a trash bag, but you got to mark it as medical waste. Okay, so what is important to note about this is wrappers, cellophane, any of that extra stuff that is not actually contaminated with body fluids is not considered medical waste. Okay, and we don't want to fill up our red bags with just garbage. Okay, so try to keep those two things separate. These biohazard bags are not gigantic, and over an extended event, you can accumulate quite a bit of real honest medical waste. So try to keep that separate. Keep your garbage separate from the biohazard bags. Okay, when is it okay to leave it on site? Very often in a CERT type situation, you've entered into somebody's home, or you are, somewhere out in your neighborhood. It's okay. It's considered okay to leave medical waste actually at the site. Either, because it's a family and, it's not considered, particularly risky to leave it with a family, or if it is more or less understood that professionals will be arriving at some point, in which case they can dispose of the medical waste themselves. Okay, bury human waste. That's a whole different department in and of itself. with regards to long extended disaster situations, very similar to like what is going on with Turkey and that sort of thing, because over days and days and days, human waste becomes a sincere hazard with regards to transmitting disease. Anyway, we all know this. If it's wet and it's not yours, don't touch it. Okay. Anyway, let's talk about water. Okay, so with water, this is, to make water potable for drinking, but you also have to think in terms of, it isn't just for water, for drinking, that it is also being used for flushing wounds and administering first aid. But it's the same thing. It's the same, whether it's drinking water or whether it's water that's going to be used for first aid. Okay, boiling water for 1 minute. That means a solid rolling boil. That means big old bubbles, right? For a full minute, right? If you have water purification tablets, that's great. That's awesome. If you've got one of those straws, those filtration straws, that's really great. But, for my money, boiling it for 1 minute, like serious boiling, should kill any of the viruses or any of the germs that we need to be concerning ourselves with. The important thing, though, is you should let the water stand for 30 minutes before actually adding the bleach. Because what happens if you've got hot water, you take it off the burner, and if the water is hot and you go through all the trouble to put this sanitizing bleach in, if the water's hot, it's going to basically deactivate the bleach, and it basically isn't going to be doing you any good. Okay, so 1 minute rolling boil, let it stand for 30 minutes to cool off, then add your 8 drops of liquid bleach per gallon of water. Okay, and as you can see, if you want more information about like making your own drinking water, there's the CDC website. Okay, all right. Now let's talk about emergency medical operations, about the whole thing, but what it is that the medical operations is concerned with. Okay, well, various different functions, triage being one of them, right? This is a multi-casualty incident. We have multiple people that are needing our help. How do we organize ourselves? How do we organize and prioritize who needs what first? And that is what triage is for. Transport. Well, transport we can be talking about a number of different things. Transport is basically taking into account if and when the appropriate transport has been organized, whether it's a series of ambulances, whether it's the National Guard and their transport and that sort of thing. We have to think in terms of the very, very most seriously injured individuals will at some point need to be transported to a professional facility, but we don't know, depending on the circumstances, when that actually is. So knowing that, how are we as CERTs going to provide our an appropriate treatment given our skill level? Establishing a morgue. Establishing a morgue is, kind of an unfortunate aspect of these kinds of situations, but taking into account doing the appropriate thing with regards to establishing a morgue away from where it is that people are being treated is an important consideration. Now, I want to make a point here about this, which with regards to CERT responsibilities, we do not move any deceased people. As CERTs, we leave deceased people where they are. So by establishing a morgue, what we mean by that is if we have established a first aid area where we are treating people who are immediate, delayed, walking wounded. And if somebody happens to pass away in our treatment area, we have to have established a morgue area where they can be placed. Okay, nothing more than that. And then, of course, medical operations. I mean, we go through a lot of supplies, so that's a very important role within our medical, emergency medical operations, is to ensure that we have adequate supplies in order to do our job. Okay, so here's a situation. So we've got an event. Something happened, right? And we have reports of people who are injured. So a site has to be set up to be the treatment area. Okay, it's important for you guys to understand that at this point, we are not transporting injured individuals to a treatment area. So you can think in terms of, depending on what the situation is, it could be a larger scale treatment area where people will be brought by family members, neighbors, that sort of thing. We can establish a larger treatment area, or it could be a smaller treatment area that is like in let's say a smaller neighborhood. And let's say, for example, it may be necessary for one small area to actually set up kind of a mini treatment area, but it all works the same way. And what that means is that when a treatment area is and has been identified, whoever does the determination has to take in several factors. Number one, is this treatment area that you've chosen, okay, taking into account the safety of the rescuers, meaning, is it going to be safe for the rescuers over time? Also, for the safety of the survivors, is this a is this a hillside that's going to give way? Is this in an area that has let's say that there's like leaking chemicals or something like that? Is they have to take this sort of thing into account, that whatever area that you decide on, that it is going to be safe for all people over time. Is it in a place where we have the most effective use of resources? So there could be a water source, it could be a lighting source, that sort of thing. Is it a protected area? That sort of thing. And also something to take into account, is there a pathway or a road for potential transportation to be set up? Is there a way for the ambulance at some point be able to get to that area to scoop up the people and take them into the hospital? So when making those kinds of decisions, your area should be safe. Okay, if there is a potential with a chemical leak or potential for a fire or something, always make sure that whatever your treatment site is going to be placed upwind, uphill, or upstream of any hazard zone. Okay, also, like I said, it has to be accessible by potential transportation and expandable, and it should be easily moved should the situation change. The wind changes, there's an aftershock, and all of a sudden that treatment site has become unsafe. Okay, it may be necessary to move it. So all these things have to be taken in consideration when deciding on how or where to set up your treatment area. Okay, so this is kind of what it would look like. What you can imagine what a treatment area would look like, whether you're using red, yellow, or green tarps on the ground, or whether you're using red, yellow, or green tape to identify the various different areas. You can see here that your morgue is placed quite a bit away from the actual treatment area. Okay, transport of reds, of course, they're going to go first, and they need to be closest to whatever area, transportation, any road egress, that sort of thing, to make sure that reds are in a place that can be moved if and when transportation actually becomes available. Okay, all right, so your job. Okay, so your job, having set up your treatment area, okay, not only is going to be tending to the patient, but also doing some documentation. And I'm not going to spend any time actually talking about the documentation, but I think you may have already covered that a little bit. But just to kind of emphasize that documentation, when you're talking about helping somebody medically, is going to be pretty important, because interestingly enough, if you really think about it, if there's like a major disaster, this person may be barefoot, their wallet is home or somewhere else, their purse, it may, what you're doing as far as documenting may be their only identification of any kind at all. I mean, John and Jane Does are a big problem when we're talking about a disaster kind of situation, because how are we going to figure out who their, who their loved ones are, that sort of thing, if they're not conscious, for example, that sort of thing. So identifying information is really important. Okay, so we got to make sure that you document it. All right. Remember, you work as a team. So if it's your job to actually administer the first aid, make sure that you've got a scribe, that you've got somebody actually writing down the answers to the questions that you're posing to your patient. Or if that patient is not able to respond to you, actually to have them write down a description of the person, approximate age, gender, height and weight. That's really hard, especially if they're laying on the ground. It's kind of hard to do. Anyway, but also to, injuries sustained. Okay, what was done? Basically, what kind of treatment was done? People very often, can show up, in with one, kind of set of issues, and over time, over an extended period of time, the condition could change, and that needs to be documented. Okay, so filling out the documentation to the best of your abilities over time in the treatment area is absolutely key, because like I said, this may be the only way anybody has of identifying this person or knowing what is wrong with them. Okay, so I think Karen talked about this quite a bit. Okay, your priorities when treating your patients is to address the 3 killers first and foremost. Okay, and I know we remember this. Ensure a clear and open patent airway. If they don't have an open airway, they're done for. And bleeding and shock is just not going to be an issue, because they're going to be goners. Okay, so control your 3 killers. Make sure you got an open airway, control any life-threatening bleeding, and if they're exhibiting any signs of shock, treat for shock. 32 can do. Remember, 32 can do. Less than 30 respirations is what you want, right? Less than 2 seconds capillary refill, and that they can follow they can actually follow commands. Anything other than that, beyond that, they are going to be categorized red, and they are going to be your priority. Okay, knowing how to do this will make all the difference in the world, and really honestly being able to sort out who is an immediate and who is not. If you don't get a lot of good practice with this, or if you've got any questions about this or kind of unsure of yourself, make sure that you address this when you actually do your hands-on stuff, because what I've noticed is that people who are not particularly comfortable with doing the triage 32 can do end up making everybody an immediate. And if everybody's an immediate, you've kind of messed up the reason to have triage in the first place. So let's get it clear. Make sure everybody's pretty comfortable with that. Okay, so we're going to talk about the head to toe assessment. Okay, so trying to teach head to toe assessment on Zoom is kind of hard. And because obviously it is a hands-on skill. But what I'm going to do is I'm going to, kind of talk you through kind of what I know to be kind of like the key points in doing a head to toe assessment, and just what I have learned over the years of actually doing these head to toes on real people and what it kind of tells me. So what is the point of a head to toe assessment? Well, okay, so somebody has shown up to your treatment area, and people are amazingly like unaware of their bodies and how their bodies work. So it's kind of going to be on you to kind of ascertain what is going on with them. What kinds of injuries are we dealing? Because they're going, oh, I hurt everywhere, everything hurts. I don't know what happened. I'm confused. I'm upset. That sort of thing. So by doing a head to toe exam on your patient, you can actually determine pretty accurately the extent of their injuries and determine whether there is any kind of treatment that you as a trained CERT can actually provide them in the interim before they actually get seen by the professionals. Also, during when you're doing the head to toe assessment, any changes in the person's condition over time by doing a head to toe assessment. These are physical injuries that the head to toe assessment will give you information. Okay, all that, whatever it is that you end up doing, whatever your findings are, any kinds of treatments that you do, all have to be documented as a result of a good head to toe assessment. Okay, if there was time, and if you had the appropriate number of people, a head to toe assessment on all individuals who have come to your treatment area, even those who kind of seem okay and were initially tagged green. Obviously, those people are not our priority initially. Okay, head to toe assessment is a really super good tool to be able to determine if there's anything that you can do for them with regards to first aid. Okay, so a couple of things. So we put ourselves in a situation where we have a patient. Identify yourself. That's, if it was me, I mean, put yourself in the patient's shoes, right? If here you are, you've been plopped down on the red tarp, you don't know exactly who this person is, right? And it's like, who is this person in the green vest and the gloves? Identify yourself. Say, identify yourself. Hi, I'm so and so. I'm trained in first aid. I'm going to help you. Okay, so this is what I find works for me with regards to getting permission from a patient. Because if I say, I'm Anne Marie, I'm CERT trained, may I help you? They have no idea. They have no idea whether you can help them or not. So what I found works really well with regards to getting permission is just say, I'm trained in first aid. I'm going to help you. Okay. And then they say, okay. When they say, okay, now permission has now been granted. Okay. Another thing to take into account, of course, is to respect their privacy. It's tough, if you've, and if they've got, they're bleeding from the shoulder or something like that, I mean, to kind of take into account that there's probably a lot of people milling around, that sort of thing. And, kind of take into account that, a little consideration for modesty is always appreciated. Okay. When they talk about look for medical identification, this is for people who are not conscious or not responsive, and that may help in your documentation. So when we're talking about that, we're talking about medical bracelets. We're talking about the medical necklaces as some kind of medical identification that can tell you, this person's a diabetic. Oh, we need to keep an eye on this person. Make sure that ask them some questions about their medications. Make sure that they, that if they're needing food, that sort of thing. Also, if they have severe allergies to things, knowing that is important information. Says here, patient has the right to refuse treatment. Absolutely. Every single person over the age of 18 has the right to say, no, 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 don't touch me. Okay. That's absolutely true. And they can refuse it of paramedics, fire department, and anything. That's just kind of the way it works. But if that person somehow or another says, no, 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 don't touch me, and then suddenly, as a result of their injuries, they suddenly become unconscious, well, guess what? I guess permission is now implied. Okay, in which case we're going to help them out. When you're doing this patient assessment, sure, you've identified yourself, you've gotten permission. Make sure you're going to talk to the patient. Tell them what you're going to do. That's kind of important for you to kind of say, okay, this is what I'm going to do. I'm going to be checking you for injuries, okay? And if anything, tell them what you're going to do. I'm going to touch you, okay? And you tell me if anything hurts. Okay, and obviously you would have that conversation with a conscious person. If you don't have that, if you are not able to communicate with that person, you're going to have to rely on your own eyes, your own ears, and what it is that you're able to feel with your hands in order to do an assessment of this person's injuries. Okay, and we'll talk a little bit more about that. Kind of be aware of any mechanism of injury. When we're talking about a mechanism of injury, is that trying to ascertain from the patient, perhaps, what was it that you think caused this particular injury? Let's say they got their lower leg is, completely screwed up and turned the other way. They're pointing in the opposite direction or something. Consider the mechanism of injury. Did something fall on them, for example? Were they hit by falling debris? Did they fall in a hole? Did they turn their ankle in a hole? Think about the mechanism of injury, and that can give you some ideas, the potential of what you could possibly expect to see with that patient. If they were hit in the head, would I suspect that there probably was perhaps a potential for a skull fracture, or maybe a neck injury, something like that? Absolutely. So, just kind of, be aware of any mechanism that could have caused that injury. Children are assessed toe to head. This is just kind of FYI. The reason that we go toe to head with kids as opposed to head to toe is because if an adult comes at a kid and immediately starts touching their head, it's a little disconcerting. So if you start with the toes and kind of work your way up slowly, it's a lot less intimidating for the child. Okay, be systematic. That's what the whole head to toe assessment is supposed to be, because you don't do it all the time. So if you're systematic, you'll remember. Just going in order, you'll remember and make sure that you actually assess every single part of that person's body. Okay, you got a partner, ask the patient. We've probably all been asked this at one time or another. Okay, how bad is the pain? 0 is none, 10 is the worst pain that you've ever had. You can just ask them. Figure, not generally, but if let's say you touch their knee and they go, ow, 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 you say, how bad was that? Was 0 being none, 10 unbearable, say, oh, that was a 5, that sort of thing, and you document it. Okay, so this is a hands-on assessment. That means you use your hands to give you information. Okay, if you feel something that doesn't feel quite right, what you would expect to feel in that particular part of that person's body, okay, you're going to document it. All right, be checking your own your gloves for signs that that person is bleeding in places that aren't necessarily obvious. Very often when you're talking about building collapses, any kind of damage and everything, these people are not nice and clean. They are covered with sheetrock dust, dirt, mud, water, oil. I mean, could be anything. It may not be really obvious to you. Okay. Also, when you're doing this head to toe assessment, you're going to be checking what we call CSM, circulation, sensation, and motion for all extremities. And when I actually start talking about the specifics of the head to toe assessment, I'll point that out about what that is. It says everybody gets tagged. Well, that's another discussion with regards to triage tags and medical tags. Anyway, so look for the killers first. Before you start doing the head to toe assessment, check to make sure airway is clear, you've controlled any excessive bleeding, and the patient is not exhibiting signs of shock. Okay, look for head and neck injuries. That's that mechanism of injury. Take that into account. Okay, then look for any other injuries using that head to toe. Okay, what are we talking about with our concerns for head or neck spinal injury? This person is exhibiting any diminished consciousness, right? That person is obviously a red, right? Because they failed mental, the M part of RPMs. Inability to move an uninjured body part, right? I can't move my legs. I can't feel my legs. Severe pain directly over the spine. Like I said, any mechanism of injury that would give you reason to suspect that there may be a head, neck, or spinal injury. Okay, now there's nothing that you can do at this level, at the CERT level, for any of these really serious injuries, but it's really important that you document it. So when we pass that patient over to the professionals, that they take that into account. Okay, now, any of these kinds of injuries, spinal injuries, okay, we do not move patients. Okay, the only time we move patients, let's say, for example, if we set up let's say we set up a mini treatment area, in a neighborhood, that sort of thing. If any of these patients are injured to this extent, we would only move them if the scene became suddenly unsafe. A fire broke out. The ground became unstable. The building next to you became unstable. Any of these people with with any of the serious injuries, that sort of thing, we don't move them. Okay, so we keep them, we protect them, but we keep them where they are. All right. I don't think we're gonna, I hope everybody had an opportunity to actually watch the head to toe assessment video. If not, then after this, I highly recommend that you actually do take a look at it. I'm going to talk a bit about what you actually find when you're doing a head to toe assessment. You start at the head, that's very true. But what are you looking for? What are you feeling for? All right. And these are the things that you're going to be looking for or feeling for. All right. And I'm going to talk about them individually, but we use this mnemonic in emergency medicine. We call it DCAP BTLS. And I'm not going to go into them individually right now, but just know that these are the things you're looking for, specific feedback. You're just not giving this person a massage. Okay, you're actually getting feedback through your fingers, using your eyes to be able to see what kinds of injuries and to the extent these injuries actually are. Okay, and with doing a head to toe assessment, we start with the head and we work our way down. Okay, always communicate with the patient, let them know what you're doing. Okay, so I put up these little anatomically incorrect people right here so I could actually talk about these a little bit. So using your fingers, okay, using your fingers to actually feel the person's head. And what I mean by that is that what you're going to do is you're going to be starting at the top of the head. And with your fingers spread out, you're going to be feeling the skull. You're going to be feeling the skull. It could be bloody, don't know. Scalp injuries have a tendency to bleed like hell. It looks a lot worse than it actually is. But what you're feeling for any crunchies, any bumps, anything like that. You're going to be looking in the ears, looking to see if you can see any blood in the ears, any blood in the nose. So you're basically, I mean, this is your brain. This is kind of important, right? To make sure that this person's, to be able to document any potential injuries that this person has in their head. Okay. Also the neck, right? Really important, right? It's a very important part of the body, right? It's the thing that holds your head on, right? It's your 12-pound bowling ball on a stick, right? So necks, when we're talking about traumatic injuries, has the potential to be, you know, pretty serious. So what you're going to do is you're going to feel around to the back of the neck at the spine and feel to see whether the spine is actually in line and whether the patient is actually eliciting any pain. If the person is conscious, they'll go, either that hurts or that doesn't hurt. If the person is semi-conscious, they may wince, make a face because that hurts. You would document it, right? And then you move down to the shoulders. During a disaster, what do people do mostly? They usually run, right? You know, we talk about with an earthquake, you're supposed to, you know, you're supposed to stop, drop, right? And get under a table, you know, and hold on, that sort of thing. What do people normally do? What they do is they run. They run and they fall. They trip and they put their hands out in front of them. And invariably what that causes is it causes broken collarbones. This is usually how broken collarbones break. So in checking shoulders, one hand on each shoulder, give them a squeeze. If you're feeling anything out of the ordinary in that area, right? If the patient screams their head off, then I guess they would know that you have some kind of an issue there. You would document shoulders. Okay. Chest. How do we check chest? Chest, and you'll see this when you actually get a chance to do this real time. I mean, this is where, you know, when you actually do it real time in practice, then you'll really get a sense of how this works. But you're going to make a kind of a knife shape with your hand, and you're going to run it down the center of the chest. And what you're checking for is you're checking the sternum, the breastbone, to make sure that the breastbone is intact, that there hasn't been some kind of a crush injury that may have broken the breastbone, that sort of thing. So you're going to be feeling for that. It mentions this in the video, checking for crepitus. Crepitus is a term that basically means crunch. It means, do you feel any crunchy, which kind of lets you know that you have broken bones in that area. So just run the blade down the chest, pressing slightly, no crepitus, then you move on to the next thing. All right, then you've got arms and hands. All right, so the thing that you want to make sure that you use your fingers, your entire, both hands, to kind of check the entire circumference of the upper arm, the lower arms on both sides. Now with hands, you're going to look at the hands, but this is what you're going to do. You're going to check that circulation, sensation, and movement with the hands by asking the patient to squeeze your hand, both hands. Okay, so you're going to run your hands, checking all the way down the arm, ask them to squeeze your hand. That's letting you know that the circuitry and the muscularity, the signals from the brain are going all the way down to the hands, and they're able to squeeze your hands. Okay, that is checking that. Okay, and you would do that on both sides, right? The other thing that you're going to check now is the rib cage. You've done both hands. Now you're going to do the rib cage. Now you put your hands around both sides of the ribs. Ask the patient to take a deep breath. And you should feel both sides rise and fall. Okay, if only one side rises, the other side doesn't, we have a concern perhaps for some broken ribs. If the patient is conscious, oh, they'll let you know because they will be in pain and they will have a hard time breathing. Okay. Then we move to the abdomen. Now, the thing about the abdomen is it's very, it's soft. I mean, it's your guts, right? So it's very unprotected. All that other stuff that we were checking, this stuff is pretty good, structurally as far as protecting you. But the abdomen is cause for concern. So what you do is you take the belly button, and from the belly button, you're going to divide the abdomen into 4 quadrants. Okay. And what you're going to do with the flat of your hands, the flat of your fingers, you're going to press once in each quadrant. Press, 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 press. And what you're doing is you're checking for any kind of injury, any kind of internal bleeding that would cause a solid mass in what is otherwise a very squishy tummy. Okay. Also, if you are eliciting any pain for your patient by pressing on the belly. Okay. Then you move down to the pelvis. Pelvis is a very big, very heavy, bony structure. And people who fall are susceptible for having a fracture. So what you're going to do is you put your hands on either side of the pelvis, and you're going to squeeze together, squeeze the pelvis together, and then you're going to rock it back and forth. Okay, and what you're checking for is you're checking for the integrity of the pelvis. If there's any kind of issue, anything that feels not solid, then you have to document that. Legs, in doing your legs, the best way to do this, because our legs are big, our legs are bigger than the width of our hands. What I have always done in order to maintain a little bit of kind of respect for the person's body, that sort of thing. You still start at the very, very top of the leg, but one hand on bottom, one hand on top, not side to side. One hand on bottom, one hand on top, and you're going to be feeling all the way down that person's thigh. Stop at the knee. Kneecaps have a way of wandering when people get injured. Check to make sure that the kneecap is intact. Then work all the way down to the ankles. Okay, do that on both sides. Okay, do not step over your patient. Okay, this is something that we make a big deal about when we are doing a head-to-toe assessment, because our patients are on the ground. Do not step over them to get to the other side. Walk around them. Okay, it's one of the worst things you can do is step over a patient. Okay, just keep that in mind. Okay, now we're at the feet. Okay, and now we can check circulation, sensation, and movement in the feet by basically having them press on our hands like a gas pedal. Put the palms of your hands on the base of their feet and have them press down, okay, like it's a gas pedal. Okay, and that's letting you know that we have a solid connection from the brain to the feet. In order to check that. Okay. Now, the only thing that we haven't checked now is that we haven't checked the back. All right. And it's kind of hidden, right? It's kind of a hidden part of the body. So this is where your teamwork comes into play. All right. That person is to be turned on their side, but one person is controlling the head and the other person is rolling that person on their side. In the video, what they have you do is they take the arm that is closest to the CERT member, have them raise their arm over their head, and you're going to roll that patient over onto their arm. Basically, that raised arm acts as a pillow to support their head. But One person is supporting the head, keeping the head in line with the spine, and the other person is turning them on their side and then running their fingers down the spine to make sure the spine is that the spine is straight and there is no excessive bleeding or anything going on in that area. And that's pretty much how a head to toe assessment works. And you'll have a chance to actually practice and get good at that. Now, let's talk about these guys. So, we're feeling, you know, that kind of stuff. So what are we actually looking at here, or we're looking at and feeling for? So decap BTLS. Let's talk about deformities first. So deformities, sometimes deformities can be like really obvious, like this one, for example. Okay, there's an obvious deformity. How do we know it's a deformity? Because interestingly enough, this arm has its identical twin on the other side, right? If you're not sure whether this person actually has a deformity or not, check the other arm or check the other leg, because they have another one just like it on the other side. Okay, deformities can be caused by a number of different things, but that's the D in decap BTLS, is to check for deformities. Okay. Contusions. Contusions are basically a bruise. It's also, it could be like a skinned knee, for example. It's basically kind of diffuse, very superficial, doesn't bleed in a lot. But you'll notice in a situation like this, we have a bump in the head. And that, of course, could be, could signal something a little bit more, concerning than just a small amount of soft tissue damage. Okay, so a contusion could be a bump or a bruise. Okay, abrasions. This is more about that abrasion in and of itself. This is like very superficial as far as the skin is concerned. Skinned knee, that sort of thing. It usually hurts like heck because all those nerve endings have been exposed, but not considered serious, right? Doesn't bleed very much, but is definitely a route for infection. So it's something that you want to stay cognizant of and make sure is kept clean. Okay, punctures, yeah, perforation usually don't bleed very much. Sometimes the object is still in the person's skin. We don't have any way, really, unless we actually know what it actually caused the puncture in the first place. We don't know necessarily how deep it goes. Could be a 6-inch nail, or it could be something very tiny. So, but the skin is broken, so we need to kind of stay cognizant of the potential for infection. Okay. Burns. We're going to talk about burns in a little bit here, because that is something that we would want to concern ourselves with, and that we can actually help in the field. Tenderness is what I was talking about. When you see the patient, the CERT here is actually using the 4-quadrant method of pressing on each quadrant to find out if there is any pain or discomfort, any tenderness, any like solid swelling or anything in that area. So checking by touching the patient, you're going to find out if there is any tenderness anywhere. Okay. And I wanted to make another point here. You can see this person's tummy, right? So if you are doing your head to toe assessment and somebody goes, ow, you have to look at it to find out what caused the ow. Okay. I know, when you're, unaccustomed to actually providing, first aid in the field, that sort of thing, you're kind of shy a little bit, a little bashful. But if you're really going to be able to help a patient out, if somebody goes ow, or if you see that there's an area in that person's clothing where they're bleeding, you've got to look at it to actually see, what's going on. actually get like a full idea, full assessment about what is going on there. You can't go by just what their clothing seems to indicate. Okay. Lacerations, good old cut. Could be deep, could be superficial, right? But it bleeds. And then swelling, right? Could be caused by an injury, could be caused by allergic reaction to something, any number of different things that can cause swelling. So that's DCAP BTLS. Okay, these are all things that we probably at one time or another have actually experienced or actually seen ourselves. It's just a kind of an organized way of remembering what it is that you're looking for when you do your head to toe assessment. You will have an opportunity to practice doing a head to toe assessment, and you will be looking for these things. Okay. All right. So let's talk about burns. So burns in a disaster situation, is perfectly within the realm of possibility. Steam, broken water pipes, chemicals, electrical burns, radiation, less so radiation, not so much radiation necessarily, but these are the potential sources for burns. Okay. Your job is to keep you safe, right? Remember your situational size up, right? Don't go running in anywhere that is not safe, right? Stay aware of your environment and wear the appropriate PPE for the job. Okay. All right. Three different categorizations of burns, right? We have our first, second, and third degree burns, or what we call superficial, partial thickness, and full thickness burns. Okay, epidermis, your first degree burn is basically your sunburn. Okay, or sunburn-like. Somebody's face is red. It may not be caused by the sun. It may be caused by something else, but something intact, no blisters, just red and uncomfortable. Second degree, red, swollen, and blistered. Okay, it's when the blisters start forming. Okay, the potential here for infection is great because if the blisters themselves break and now become a potential open area for infection. And in a disaster situation, we really need to control that sort of thing. Third degree, very serious, very, very, very difficult to deal with in the field. Okay, third degree, this is where there was actual skin destruction. The areas themselves, the nerve endings are destroyed, so they don't feel anything. Unfortunately, the surrounding margins can be extremely painful. These people, unless they get the appropriate treatment at a burn center, their prognosis is not good in the long run. Okay, so what can we do in the situation of treating burns? Okay, obviously remove the patient from the thing that was burning them in the first place, right? The radiator, that they're laying on, or whatever, right? You are going to use cool water in an emergency disaster kind of situation. Your options are pretty limited, but some things can be really, really effective. Cool running water for up to 30 minutes, if that is at all possible. Okay. It's important to know that you cannot do like an entire body in this kind of situation because there is a potential for hypothermia, right? So if a person's whole entire body is burnt, then that's a completely different situation. But if we're talking about a scalded arm, a scalded leg, something like that, we can run water if it is available. Okay, if it's not available, then our options are limited. Cover with a dry sterile dressing if you have a situation where the skin is broken, whether it's a second degree where the blisters are broken, or definitely if we're talking about a full thickness or third degree burn. Okay, this diagram isn't meant to intimidate you or anything like that. It's just to kind of let you know that this is essentially how burns are, the extent of burns are described in the medical field. You sometimes will hear about this in like news stories. They'll say, this person, suffered second degree burns over 80% of his body. Well, what does that mean? Well, percentages are actually assigned to different parts of the body, and it has to include the front and back, right? Because we are, we're not two-dimensional or three-dimensional. So this is just FYI. Nobody's expecting you to know this. Just know that when they say don't cool more than 5% of the body at a time, that this is basically how it is, kind of organized. It's how a person's body is organized. So you're talking about a leg, so it's 9% in the front for the entire leg, right? 9% in the back for the entire leg. These are just general guidelines, right? You're not, just so you're aware, just to cool a burn. Cooling a burn is important, right? But you don't want to cause any hypothermia by kind of getting carried away with the whole thing. Okay, no ice, butter, any weird stuff on burns. Doesn't matter. I don't care what old wives, tale you grew up with, what to put on burns. Okay, nothing for burns. Okay, don't pick out any foreign material, break the blisters, right? And when we say extra caution with elderly, young children, third degree burns, any any burns that are in like major parts of the body, head, neck, hands, feet. When we say extra caution, basically what that means is you want to keep an eye on them. And when I mean keeping an eye on them, it means watch for shock, watch for indications of shock, diminishing levels of consciousness, any shivering, that sort of thing, in which case you're going to want to put them in shock position. Okay, and obviously document your paperwork to reflect the fact that they may be developing shock as a result of the burn. You'll usually find situations like that in like industrial areas, businesses, Home Depot, places like that. You gotta make sure that you really do your situational awareness thing to make sure that it's safe for you to approach, and to make sure that you're wearing the appropriate PPE. You don't know what these chemicals can do, so you have to be extra careful. Chemical burns can be kind of difficult. Make sure that the source of the burn has been removed. And how do you do that? Well, if the chemical is dry, you can brush it away. You can use like a credit card to brush it away. Also, always make sure that it's brushed away from the eyes, the patient, and yourself. Flush with lots and lots of cool running water if you have that available. Don't worry so much about that says no water. Very few chemicals actually have a reaction with water, unless you are working in a very unique environment. So I would rather copious amounts of water to flush a chemical burn. I think is probably more ideal than not. If it's a burn, apply cool, wet compresses, because if there's any pain. Also, if you don't have access to large amounts of water, could be difficult. Cover all burns with a sterile covering, just to keep it clean from the environment. Inhalation burns, these are tough. These are tough things. If somebody actually ends up breathing in heated gases, because that is usually the problem, is heated gases or smoke, you'll see respiratory distress as a sign and symptom. swelling of the upper respiratory area. You could see soot or singed hair around the nose and mouth, burns around the face and neck. This is has the potential to be a very, very serious injury, and this person has to be removed from, obviously, from the source of that and dealt with. This person is obviously tagged red or immediate. Okay, so let's talk about wound care. Because there's going to be wounds, right? And we got to figure out, what's the best use of our time with regards to taking care of wounds. First and foremost, of course, controlling life-threatening bleeding, all right, is critical to patient survival. Also, preventing any secondary infections from developing, especially in a disaster situation, because they're going to be hanging out for a while, and it's not an ideal environment for open wounds. Okay, treatment of wounds, this is what we can do: irrigate with clean water. Okay, no hydrogen peroxide. Hydrogen peroxide, while really super great when you have it underneath the sink in your bathroom, but in a disaster situation, hydrogen peroxide kills live tissue as well as takes care of dead tissue, and that could lead to necrotic tissue over time. So treatment of wounds: flush with lots of water, keeping clean. Don't worry about ointments or any of that other kind of stuff. Apply a sterile dressing and apply a bandage to hold that dressing in place. And that is how, once you've controlled the bleeding, that's how you're going to do it. Okay, dressings. What's the difference between dressings and bandages? Dressings are those sterile pads that you're actually going to lay on top of the wound. Okay, you can, their purposes are multi, but this is what you want. You're going to use these dressings to stop life-threatening bleeding, right? You're going to be applying direct pressure with these dressings. And then once that bleeding is stopped, then you're going to secure everything in place by using a bandage. These are the roller gauze. These are the, kind of like athletic tape sort of things that actually will hold the dressings in place. And it's kind of important to know how to do this, because once they get all bandaged up and everything, you may send them on their way, and they're going to be hanging out on a picnic table for, the next 24 hours, 36 hours, that sort of thing. So, doing a good job with for dressing their wounds is definitely something that we want to keep in mind. Thing about dressing wounds, as in splinting, or anything like that, we always want to make sure that we check circulation, sensation, and movement prior to actually applying the bandage, and then checking it again afterwards. And the whole reason behind that, of course, is that if anybody has ever put a roller bandage around their arm or around their leg or around their finger, or put a Band-Aid on their finger, and after a few minutes it starts to go numb, it's because they've got it on too tight. Okay, so this is why checking for capillary refill, if you're putting it on an extremity, you're putting it on your arm, checking for circulation to make sure it's not too tight. The patient will usually tell you, hey, that doesn't feel good. Don't do it so tight. Okay, this is, the whole point behind checking CSM is to make sure that what you end up with after you bandaged is what you started with. So if we get a baseline by determining CSM ahead of time, we shouldn't get anything too much different after the fact. Okay, so these are just photographs irrigating the wound with water. If there's any significant debris, like large pieces of debris, you would use a sterile tweezers to take it out. Dab the wound with cotton. Don't scrub. Then cover it with the dressing, and then secure it with the bandage. And they've got some instructions on how to use a roller bandage on how to apply that over the dressing. You can kind of ascertain from the pictures here about how you kind of want to wind it up, secure it, anchor it, secure it, and just make sure that you don't do it too tightly, but you should be talking to the patient. They talk about start away from the heart and work towards the heart when you're winding it up. So if this is your lower leg, or if this is your forearm, if you are using a bandage and winding the bandage up the person's arm or leg like a mummy, okay, you start at the farthest end and you wind on the way up. And the reason why you do that is if there is any swelling, you want to bring the swelling up to the main part of the body as opposed to trapping it at their foot or at their hand. Something to bear in mind. Yeah, well, that's kind of the way it looks at nice, real pretty, put a little bow on it. Anyway, impaled objects, because there's a lot of debris. You want to kind of keep that in mind. The important takeaway about impaled objects: don't remove them. Okay. If you've got something that is, impaled on in a person's body, it's probably controlling the bleeding, right? If you go to yank it out, chances are that by removing that object, you could start bleeding all afresh. So your goal when you are bandaging somebody with an impalement of any kind is to immobilize the object. Basically, what you want to do is you want to keep it from moving any further, because if it starts moving around, right, it's going to create even more damage, cause even more pain. So stabilizing, you can get pretty creative with your ways of actually stabilizing an impalement, but it usually incorporates the use of a lot of bandages and dressings. Okay, that should be removed by a professional in a more sterile environment than what we can provide. Okay, this is just an example of a fancy kind of dressing that has seen frequent use in the battleground, like in the military. Just an example of that. Amputations, this could happen, right? So when you're finding, what are you going to do with a body part, that sort of thing. So controlling bleeding and elevating the hand or the foot or whatever it is that's, is remaining, retrieve the tissue part and wrap it in, a sterile piece of gauze, put in a baggie if you can with the patient's name, date and time. Keep the appendage dry, okay, and cool, not frozen. Don't put it in a bag of ice, but kind of have it kind of close by, right? And keep it with the patient, associated with the patient. And it's amazing what microsurgery techniques can afford right now, as far as reattachment sorts of things are concerned. So just something for you to know about. Infections kind of, that's going to be a big concern of ours, because we don't get to go to the nice, sterile, wonderful hospital for a long, long time. So how do we, keep an eye out for things like infection? This is a great example of some infection that is slowly progressing its way up this person's leg. Pain, swelling, warm to the touch. What they've shown here is they've actually drawn at a specific date and time when they observe the infection actually starting, and just to give the hospital people or the paramedic people a notion about how quickly this infection is spreading. Okay, not much we can do for them other than to observe and document accordingly. Okay, injuries. So these are, more mechanical injuries to bones, muscles, and joints. We don't have a field X-ray machine, so we don't have any way of determining whether things are sprained, strains, or or fractures. But we do know that we can identify with a head-to-toe assessment whether there's tenderness at an injury site, any swelling, bruising, any restricted use, or not an inability to actually use an extremity. Okay. Just like what we were talking about when we were talking about dressing a wound, we are checking CSM before we actually treat for injuries to bones, muscles, and joints. Okay. The goal here with these types of injuries is to immobilize. That means keep it from moving as much as possible. And we can do that by a number of different ways with splinting and that sort of thing. But keeping that area quiet will do much for helping that patient out. Because let's face it, these kinds of injuries are extremely painful, can be extremely painful, and we want to immobilize it, because when that area is perfectly still, then the pain is controlled, at least to some degree. So when they talk about immobilization, if you've got an injury at an injury site, you've got it a potential for a fracture. Treat everything as if it was a fracture. Okay. If you've got an injured area, what you want to do is immobilize, but immobilize all the way above and below the injury area to their respective joint. So what that means is, if you've got in the middle of your lower leg, for example, what looks like has the potential to be a fracture, you want to immobilize the joint, the knee joint, as well as the ankle joint. Okay, above and below the injured site. And by immobilizing that, you're controlling all the tendons, all the ligaments, all the muscles that are kind of strung along that structure. Okay. So that's the way that you're going to treat that. Okay. Let's see here. Talk about strains, and sprains. This is just FYI. We don't actually diagnose this sort of thing, but just to let you know that a strain is muscles, mostly sprains are ligaments. This is kind of a situation where you've got some bleeding of a ligament. Okay, strains and sprains, check circulation, sensation, and motion before treatment. Like I said, like if you were going to splint, for example, check ahead of time. Do your splinting, check it again. As far as treatment over time, we use this RICE mnemonic, which is rest it, obviously, don't use it. Ice, compression, and elevation. And those of us who have participated in any sports over the years kind of know that already. Okay. All right. Dislocations, that could happen. You could have that. We don't reduce dislocations. Okay, we treat them as if they were fractured. We are going to splint them to immobilize it, to keep them quiet. Okay. Again, checking CSM before and after. Okay. Fractures, different fractures. There's just, fractures that we can't see, but we have swelling and pain. We have closed displaced, which is basically more severe of a fracture, and you'll probably get some swelling in that area. And then you have your open fracture. And that's basically where the skin is broken. And then, again, a potential run for infection. All of these get treated exactly the same. We immobilize them. Okay, here's a situation here where I said if it was a bone or an area that was between two joints, we immobilize the joint above and below. So that means we immobilize the elbow, and we also immobilize the wrist. Okay, all right. How do you treat an open fracture? With an open fracture, we don't push the bone back in. All right, all we're gonna do is place a moist gauze over the bone, and that's just to keep down the potential for a route for infection. Okay, you're gonna cover the wound with a sterile dressing, and then splint the fracture without disturbing the wound. Okay, I'm gonna teach it exactly the same way. Okay, don't push it in, don't irrigate the wound, you're just gonna cover it up to keep any potential infection from happening. Okay, all right. Types of splints. You can get really creative with splinting. Sometimes, and you can use things that we wouldn't normally use for splints. We can use magazines, we can use pool noodles, we can use all kinds of different things. But the goal is always the same, and that is to immobilize the injured area. So these are perfect examples, right? We can use your body, like another finger to stabilize an injured finger. So you can splint it up against that part of the body. You can do the same thing, one leg to another leg, if that was the only option you had. Pillows, towels, socks, that sort of thing, or nice soft areas, which you see in a situation here, like with that lower leg. They've got it extended above the knee and at the ankle, so that area is immobilized, so it's not going to be moving. If this is all you've got, using rigid cardboard, broomsticks, that sort of thing, again, the goal is the same, and that is to completely immobilize it, to keep it from moving. Anybody here listening who has broken anything, you know how painful it is while it is broken to actually have any movement with it. So the best that we can do for them in the field, because we don't have morphine, is to immobilize. Okay. Again, CSM, always make a big deal about this, right? Don't use the injured part as the template. So if you're going to measure, for example, a piece of cardboard, and use that as, for example, as a splint, use the uninjured side to measure, because if you're using the injured part, you're probably going to hurt them more. So, they got another leg just like it on the other side. So use that one, okay? Splint it in the position you find it, meaning don't try to straighten it out. If it's in kind of a weird position or something like that, you're going to splint it in that position that you find it. Okay. Remove jewelry if possible, meaning that if they're anticipating any kind of significant swelling, this goes for burns or any kind of injury. If you've got rings, that sort of thing, they're just saying, remove it, tag it, keep it with the patient. Okay. Fill the voids. Especially if you're using hard materials as splints, like cardboard and that sort of thing, fill it with towels. It'll really help with the patient's comfort. Okay. And again, after you've done it, check circulation, your CSM, your sensation and movement. Okay. These are instructions on how to make a sling. Okay, so I'm not going to spend too much time on this, but these slings come in your basic, just basically come in your basic first aid kit. Kind of on the short end, you just put a little knot there. See that knot? That knot goes right where your elbow is. It fits where your elbow is, and so that leaves you those two tails. One goes on the opposite shoulder from the injured side, as you can see from the picture, and then the other one goes up. Is tied at the back, and you make sure that the knot is not on the spine, it's just moved up to the side. Okay, make sure that the patient is comfortable like that. If it's not comfortable, that may not be an appropriate option, but walking around day after day with an injured arm, you kind of get tired of holding it up yourself, so a sling could be a good option. Okay. And we're not going to practice that right now. Let's talk about bites and stings. Bites and stings. All right. If the stinger is present, You can remove it by using a stiff edge thing like a credit card to actually kind of scrape it off the skin, wash the site with soap and water, and then apply ice 10 minutes on, 10 minutes off. Okay, this is just basic first aid stuff. Okay, anaphylaxis, serious allergic reaction. Okay, these are for people who are seriously allergic to something. Could be anything. All right, these people know they have serious allergies, and they carry, hopefully with them, an epinephrine auto-injector, an EpiPen. You can help them. You can help them administer it. They can give you instructions on how to do it, but there's also instructions on the EpiPen itself. Make sure that it is that person's EpiPen. You don't give other people's EpiPens to other people. Okay. You keep an eye on them. You help them write the time administered on the patient's forehead, which is helpful. And you're checking for shock because this person will show signs of difficulty breathing. Okay. And oops. And you're going to wait for 5 minutes. Very often they have 2 EpiPens. Wait 5 minutes. If it doesn't seem to be improving after 5 minutes, then you administer the second one. Okay. Watch for signs of shock. Treat appropriately. Protecting their airway and putting them in the recovery position. Okay. Hypothermia. We're going to talk about hypothermia. Like, oh, hypothermia is different from hyperthermia. It's hyperthermia. Okay, this is, oh, it's cold. Okay. All right. So signs and symptoms of hypothermia: redness or bluishness of the skin. You're going to have some shivering happening. Okay, this person is cold, right? Hypothermia can happen along with other things. Let's say somebody was unconscious and was laying on the concrete. So not only did they have this problem with, perhaps some kind of a brain issue or something like that, but they're also suffering from hypothermia, in which case that could be a very, very serious issue. Hypothermia, later stages, slurred speech, confusion, unpredictable behavior, that sort of thing. This person is in dire straits. So what can we do? If the clothing is wet, we're going to remove the clothing, wrap them in a blanket, sleeping bag, cover them up, head and neck. Place victim in a warm bath. That would be really great, but very often in this kind of situation, that's going to be hard to come by. Protect the get the victim out of the wind. Kind of protect them from the elements. Provide warm fluids if they are conscious, and if they are conscious enough to control their own swallow mechanism, their own gag reflex. Don't give them to people who are semi-comatose, because if they start to choke, then you've got another problem on your hands. Okay. Put unconscious people in the recovery position to protect their airway. Okay. Frostbite. Yeah, I used to say we don't worry about frostbite here, but I don't know. Nowadays, it's really hard to say. Signs and symptoms: skin discoloration, any kind of burning or tingling sensation, any numbness. And of course, you got to look at the mechanism. It's like, what were you doing? I mean, were you hanging out there for any length of time? That sort of thing. So, what you would do is to slowly warm these people using like a warm bath, if that were an option. Okay, wrap the protect the area. Protect the area with sterile, clean dressings. So Now let's talk about hyperthermia, which is the opposite of this. This is something that we need to be concerned as CERT members ourselves, because if we're in an extended situation, emergency situation, and we are working very, very diligently to be helping people out, we have to keep cognizant of our own safety and the potential of actually developing hyperthermia. Okay, so there are different levels of hyperthermia. You need to be aware of them to be able to prevent them, prevent it from progressing and getting any worse. So the three categories start with heat cramps. With heat cramps, which is basically, if you were running a marathon or something like that, and if you were dehydrated, you would experience heat cramps. And hang on a second here. And then the next is heat exhaustion, which is a little bit more. This is actually like if you were on the search and rescue team and you were clearing away debris and it was extremely hot and you were keeping up with your hydration and that sort of thing, very sweaty. Heat exhaustion, just you start feeling nauseated. It's basically, your body is starting to really overheat. Heat stroke is a very, very serious medical emergency, and this is basically when the body's temperature regulation system breaks down completely, and it isn't able to cool the body off anymore. You're not sweating anymore. Your internal temperature rises, and your brain essentially cooks, and that is a very, very, very bad late sign. Okay, so we need to pay attention to ourselves when we're working, making sure that we take sufficient breaks and stay hydrated. Here's the difference between the two. Heat exhaustion, lots of sweating, really tired, don't feel good, rapid strong pulse, cramps, dizziness, headache, could be feeling nauseated. Heat stroke, there's no more sweating. There's no more, your brain's ability to regulate body temperature has broken down. And this person is basically got one foot on the banana peel. And so those people need to be addressed. People with heat exhaustion need to be addressed to make sure that they don't progress to heat stroke. Number one, remove from the heat to a cooler environment. Immediate water immersion, depending on what it is that you have. If you've got a garden hose, shower if that's possible. Evaporative cooling, basically what we're talking about is like putting towels over the person's body that are soaked in water and like fanning them with a piece of cardboard or something like that, is to make sure that that is what that person is suffering from if you're going to be doing this kind of technique for water, for cooling the body. Sports drinks, if they are conscious, if they're able to control their gag reflex, electrolytes are always best. If not, water. Have them drink it slowly. If they drink it quickly, they may vomit. If they are vomiting, they got cramps, or it looks like they're losing consciousness, don't give them anything. If heat exhaustion doesn't improve within 15 to 20 minutes, and it looks like heat stroke might be imminent, this person, like I said, is in dire straits and needs care like immediately. Okay, it says down here, must be symptoms free for 24 hours before returning to work. That note is basically for us. So if you're taken out of the line, if you're taken off the line due to experiencing hyperthermia, you're not going to go anywhere for a while until we make sure that your body has recovered appropriately. Okay. Are there any questions to all that? I know that was a lot, and it's kind of weird that we don't have like the physical thing to look at, but to work with. But let's see if there's any questions.
Folks, you can unmute yourselves, and Anne Marie, I'm gonna, do you want to stop sharing for a second?
Sure.
And
There, oh, here we go. There's everybody.
folks, there's
there I
your
am.
trainer.
This crazy person with the crazy hair.
So anybody have any questions? That was a lot of information.
Yeah, thanks, Anne Marie. That was great.
Yeah, thank you very much. That was very interesting.
Are these
Yeah.
things we're going to practice on our all-day event?
Margaret?
Yeah, so in our all-day event, we are going to practice a combination of some of the things you learned in both MedOps. So, and it'll be team-based and fairly brief. So stopping bleed with direct pressure and tourniquet. You'll have practice putting someone in a sling. Anne Marie will be teaching how to defend the airway with the recovery position and with the head lift, chin tilt. It might be the reverse of those words. I always get it wrong. And there will be a triage exercise. So the kinds of things that you did with Karen Lum last week, identifying red, yellow, green, black, and then there will be a demonstration of a head-to-toe assessment. Then that's what we're going to have time for in the morning, along with another exercise that focuses on making sure you understand the various roles of the incident command system. Then on April the, remember I mentioned that we would have a calmer practice opportunity. So on April the 29th, which is a Saturday, we're going to take an hour and a half to 2 hours and just let people come in and practice those skills in a more relaxed atmosphere. Okay, other questions? Okay, thank you very much, Anne Marie. I'm sorry your camera didn't work tonight.
Yeah.
And so folks, let me tell you what we're going to do. I'm going to bring myself back up on the screen. You know, I didn't want to give the unit short shrift. And folks, can you mute yourselves? Let me mute all. Okay, so what we're going to do is I'm going to go over just a few slides in disaster psychology, 5-6 slides, to introduce the topic, to tee up the reason why we think it's important and why it's part of the curriculum. Then in the next couple of days, we will record a unit, and I will make that available to you. So we'll have this in 2 ways, and then at your leisure, you can look at the details of the unit then. Anna Great Van Gemeren is with us. She was going to be one of our 2 trainers on this. Marcia McLean was going to be one of our 2 trainers. Folks who are in Rossmore know Marcia. So we will, let's just tee up the basic concepts. Yes, Brent, Anne Marie was fantastic, and I'm glad that you all enjoyed it. And of course, I will make this available, because we don't expect the first time you hear it that you're gonna, you know, be able to absorb it all. So thank you again, Anne Marie, if you're still on, and you will see Anne Marie in a number of roles on March the 18th.
Whether you like it or not.
Whether you like it or not, she's going to keep your airway open.
We will have fun. I promise we'll have fun.
Okay. All right. Let me just tee up this topic. So first of all, disaster psychology. Let me, so in your packet, and we assigned as pre-work, we asked you to look at 3 tools. One was a self-help toolkit, which frankly, you know, is a very simplistic approach to sort of assessing what your general life balance skills are. Because the fact is that we're going to be going, if we have to respond in a disaster, in a natural disaster like an earthquake or something where there's a lot of traumatic events that we experience, that we experience human suffering either personally, through our teammates, or through the victims that we encounter. We need to have a baseline of some resources, some tools to draw on. So the self-help toolkit, the instructions sort of ask you for each of those items to assess how you are today, and then for each of the items to pick something out and to develop it. And what we would just suggest is all of these areas represent physical and psychological health and balance, that working on it now, working on your mechanisms to be healthy and be calm, will help you go a long way in a disaster. The other two tools that you had there was the very common meditative tool of RAIN. So look at that at your leisure, but it is a very common way to slow down what you're experiencing, to just recognize what's going on in your body, recognize what's going on in your breathing and your mind, to allow it, to allow whatever is going on there without judgment, to investigate what it feels like and without judgment, and then to nurture yourself. And the stop tool is a way for you to, when you are feeling yourself in a stressful situation, to stop, to focus on your breath, to observe what your body is feeling, and be able to promote a little bit of calm. So those tools, are just part of a total picture to combined with good nutrition, getting enough sleep, getting regular exercise, having human connections with others, having some level of spiritual connection to the earth, to organized religion, to whatever it is for you that represents spirituality. All those things, when promoted now, will help you be in good stead, better stead, when you have to help others through trauma in a disaster. So that was the purpose of the pre-work. And when we give you the recording, what you're going to learn is that you're going to want to, when you're assembling as a CERT, you're going to want to not just pay attention to what you're feeling yourself, but you're going to have to be mindful of your team members and mindful of the victims. So there will be in this unit some discussion of the emotional phases of a disaster. Everything is going along smoothly, everybody is feeling, we're having regular life, and all of a sudden some stun-producing situation happens, and we experience an impact of it. There is a period of time where we think, hey, we're fine, we can get through this. We receive some help from the government, we receive some help from others, and we start to put our lives together. But we have to remember that there may be emotions that we or others are holding in, trauma that we have experienced that is going unspoken. And even though we are reconstructing our lives and working toward improving where we are, that doesn't necessarily mean that the emotional responses that we have had are automatically going away, or that it's going away for others. And we just want to remember that the impact of trauma can be, impacts you cognitively. It might impact your ability to make decisions. It impacts you emotionally, this overwhelming feeling of helplessness, spiritually, this lack of hope. So we want you to, through this unit, learn about the various impacts of trauma on human beings, and to understand that it's very significant. And let me move through. There are ways, both emotional and physiological, to identify trauma in a human being. And these things may happen at the moment that the trauma is first introduced, but it could happen over a very long period of time, and it can emerge. So in this unit, we're going to be talking about these elements of it, and we're going to be talking about ways, as I mentioned before, that you can help yourself and others by talking with one another, listening empathetically, and starting out with the right, a healthy lifestyle that gives you tools to draw on. And so what I'm going to do is talk about the other thing that's going to happen when you go through this unit is we're going to talk a little bit about with survivors and with other CERT team members, things that we want to do and things that we want to avoid. So, as adults in our lives, we have figured some of this out already, but important just to remember not to impose on others our own perception of how they should be feeling or how they should be looking at the situation, or trying to predict the duration of their emotions and their physical symptoms, but instead listening empathetically, just making sure that they know somebody's there. Sometimes it's just sitting with another person that is important, and creating an opening for them to speak to you. So, in the very beginning, I told you that there is a role in CERT for everybody. People with all kinds of abilities have the ability just to sit with another human being and create connection, allow somebody to express emotion, feel emotion, or just have someone with them when they're experiencing trauma. I just want to mention that something that Karen mentioned, something that Anne-Marie mentioned, that of course, if we are present for a death, if we come across a dead body, we treat the body with respect, and the family with respect. We don't make any proclamations. We cover the body. We make sure that the body is kept in a separate area. We don't transport it, but just making sure that family and people are kept away from death. So we will get that unit to you. It's a shorter unit than some of the others, and please watch it. I will put you on the honor system that you will watch that. So let's turn our sights to next week. So in that build, you now have some preliminary understanding of medical implications, some first aid remedies, how to address the 3 killers, what to do in a triage situation. Next week, we're going to bring back Dawn Fair, who did your fire and utilities unit #1. She is from Alameda County Fire Department. And Dawn will go over in quite a lot of detail the process that we would undertake as CERTs if we decided that we could take on a search and rescue mission. So following an earthquake, as we've said before, if we're activated by the city, we would assemble at our command post. The first person there becomes the CERT team leader until somebody else comes along and they're ready to relinquish the responsibility. They will assign other roles as needed, but their first job is to receive from all of the CERTs who are coming in from their homes to the command post, receive what they are seeing. So CERTs in their neighborhoods will say, as they come into the command post or radio it in, here are the things I'm seeing: damage on this street, I'm seeing some casualty situations, whatever it is, down power line, down tree, gas emission, fire. The CERT team leader is going to be accumulating that information. We're putting it up on a board. The CERT team leader and the operations chief and the plans chief, working with others, are going to prioritize those things that as CERTs we have seen. And then if we have the right CERTs in sufficient number and sufficient training, sufficient capability, then the operations chief might assemble search and rescue teams, and folks who are willing to be on a team will be sent out in a targeted way to a specific neighborhood. So we're going to talk all about that process, what we do when we how we determine the level of damage in a building where we would not go in versus the level of damage where we would. We're going to talk about search markings. We're going to talk about all of the protocols related to search and to rescue activities. The second part of that night, next Tuesday, is radio communications. And so you had a little bit of that on February 4th. We're going to take it to the next step. And we're going to stop just short of ham radio. And we're bringing back radio because on March the 18th, you're going to, as a team, you're going to be in the afternoon radioing in at least one transmission for each of the 3 drill stations that we'll be going through in the afternoon. And then our final class, a week from next Tuesday, will be terrorism, which is a very brief unit. And then we're going to spend most of the time evaluating what you need in order to operate effectively as a team on the 18th.